can start present. You're fine now.
Okay. Hi, guys. Sorry about all of this confusion. We are trying to get this resolved. I practiced the share screen and the note screen at least 10 times yesterday, and it worked because we usually make notes. But anyways, I'm glad to make it work now, and we will try to do this quickly. The goal today for learning, I don't know where I had my learning objectives. And my learning objectives for you today are to know the pathophysiology and risk factors for pulmonary hypertension, identify the clinical features, and get to a differential diagnosis of hypoxemic respiratory failure, recognize the laboratory imaging and other diagnostic features of PPHN, and review the management of PPHN, which I think is most important for all of us caregivers and providers of high-risk newborn infants. So what is pulmonary hypertension of the newborn? It is actually an impaired circulatory adaptation at birth or persistent fetal circulation. So in the fetus, the umbilical venous blood flowing in from the placenta has the highest percentage oxygen saturation with a PaO2 of 27 to 35 millimeters of mercury. This oxygenated blood returning to the heart via the IVC is preferentially streamed from the right atrium to the left atrium via the patent foramen ovale to perfuse the coronary and cerebral circulations. Additionally, the deoxygenated blood returning from the heart to the SVC is preferentially streamed either to enter the right ventricle and then through the pulmonary artery to the aorta, which is a right to left shunt across the ductus arteriosus to the placenta and to perfuse the lower part of the body. So therefore, there are two shunts going on in the fetal circulation, and you are all aware of that. One is right to left shunting of blood through the PFO, and the other is right to left shunting through the ductus arteriosus. Okay? In the normal fetus, the regulation of pulmonary vascular tone in utero is critical, and low oxygen tension and various mediators maintain the elevated fetal pulmonary vascular resistance. Vasoconstriction in response to this low oxygen tension contributes to high PVR or pulmonary vascular resistance as the fetus goes to term gestation. And this fetus is accustomed to reduced pulmonary blood flow in the placenta. As you can see, only 13 to 16% of blood flows into the pulmonary vessels during the fetal life. So essentially what we are saying is that the first stage of transition is that the fetus is in a state of physiologic pulmonary hypertension. It's not that the fetal lungs are not expanded in utero. They are expanded, but the alveoli are filled with fluid. The oxygen levels in the alveoli are low compared to the postnatal levels, and the arterioles that perfuse the fetal lungs are markedly constricted, partly due to the low PO2 resulting in high pulmonary vascular resistance. So key is high pulmonary vascular resistance during the fetal life. There is no significant change observed in the pulmonary arterial or the venous PO2 because the lungs are not doing a lot of oxygenation or any oxygenation. It's the placenta that is doing it. So essentially, the fetal circulation is characterized on the right, as you can see, by high pressure and low flow because of elevated PVR, which could be both passive and active. The passive resistance is due to compression of pulmonary capillaries by this fetal lung fluid. And active vasomotor tone, along with lots of various mediators, can cause elevated pulmonary vascular resistance. So in fetus, PVR is greater than the SVR, or the systemic vascular resistance, which causes right to left flow at the PFO and the PDA. And what happens is that there are, I don't know if you can see the whole graph here, but there are dynamic changes in the PVR which are happening with gestation. At the time of birth, the fetus is accustomed to reduced pulmonary blood flow, as we said, and during the canalicular stage, there is paucity of pulmonary vessels. This is the canalicular stage, which is somewhere at the 19 to 26 weeks. There is paucity of pulmonary vessels, resulting in lower cross-sectional area of the pulmonary vascular bed and high PVR. However, at this stage, the pulmonary vasculature is not very sensitive to low oxygenation. In the saccular phase, which is what happens this one here, when the 26th week starts, there is rapid proliferation of the pulmonary vasculature, and this will contribute to very increased cross-sectional area of the pulmonary vascular bed. But at this stage, the pulmonary vessels are more susceptible to mediators of vasoconstriction, such as hypoxemia, endothelin 1, that we are going to talk. So what I'm trying to say here is that it's not a fixed problem. There is dynamic changes in a PVR, even with advancing gestational age. This will be more pertinent in the next few slides. So fetal pulmonary circulation is highly coordinated with airway growth, as we just saw. Lung vascularization initially originates in the mesenchyme distal to the epithelium, and the VEGF, vascular endothelial growth factor, stimulates the endothelial cells to move towards the epithelium, where they form the epithelium capillary interface, which is important for gas exchange. And disruption of any of this lung vascular development will play a major role in the pathobiology of pulmonary vascular disease in pulmonary hypertension. So what are the mediators of early pulmonary vascular development? Where did it go? So we have some hypoxic conditions in the fetus which support lung and vascular growth, and you have some hypoxia-inducible factors which are regulators of transcriptional response to hypoxia. And some of them are involved in angiogenesis, VEGF, which is important for oxygen transport, and energy metabolism. VEGF is a key mediator of pulmonary vascular development and increases nitric oxide and causes rapid pulmonary vasodilatation. Nitric oxide also has a key role in lung vascular growth and mediates VEGF in reduced lung angiogenesis. So here we talk about at birth what happens, the transition from fetal circulation to neonatal circulation. Air will enter the lungs, and this improves oxygenation of the pulmonary vascular bed, and pulmonary blood flow then increases, which in turn increases the pulmonary venous return and increased left atrial pressure, which will cause closure of the foramen ovale. The pulmonary vascular resistance decreases to 50% of systemic resistance. And systemic vascular resistance also increases when you clamp the umbilical cord and removal of the placenta. Therefore, the PDA flow reverses, which was initially right to left. It now becomes left to right. And subsequently, PDA will close in response to increased oxygen tension with postnatal circulatory pattern. So what happens over here one sec, is ratio of the blood that enters the pulmonary arteries or the ductus is determined by pulmonary vascular resistance and can vary with fetal oxygenation status, which again brings us to the point that this is all dynamic. You have fluid-filled alveoli here and high PVR, high levels of endothelin and serotonin, and low levels of the dilator nitric oxide and prostacyclin, and alveolar hypoxia. And then the normal transition will be where the physiologic pulmonary hypertension is resolved because of decrease in the pulmonary vascular resistance. However, if there is hypoxemia and extrapulmonary shunting, then there is abnormal transition on the right side where you can see the fetus is looking blue because of persistence of pulmonary hypertension and hypoxemic respiratory failure. In this instance, PDA is often right to left or bidirectional. So failure of normal pulmonary vascular transition is at birth is characterized by elevated pulmonary vascular resistance relative to systemic vascular resistance. And this happens because of multiple factors, one being vasoconstriction, the second being structural remodeling of the lung architecture and hypoplasia of the pulmonary vasculature. If you have sustained elevation of pulmonary vascular resistance, it will ultimately increase the afterload on the right ventricle. And with time, right ventricular failure may occur, and ultimately ischemic injury can precipitate both right and left ventricular injury. So again, as you see here, the normal situation at birth is, I don't know if you all can see my arrows. Can you all see my arrows? So this is at birth, yes, and you have elevated pulmonary vascular resistance, and it has to drop to normal levels, the pulmonary vascular resistance with increasing pulmonary blood flow. However, if there is, okay, one sec. However, if there is high levels of endothelial and serotonin and low levels of the dilator, nitric oxide and prostacyclin, then the pulmonary vascular resistance stays elevated over here, and that causes the pulmonary vasoconstriction or pulmonary hypertension. So the hallmarks are labile hypoxemia with wide swings in arterial PO2 with no changes in ventilator settings. That is the striking phenomenon in pulmonary hypertension. Hypoxemia is disproportionate to the severity of parenchymal lung disease, and that will suggest idiopathic pulmonary hypertension. Another diagnosis could be cyanotic heart disease. And if you have pulmonary oligemia due to decreased pulmonary blood flow, some of the differential diagnoses could be tetralogy, Epstein's, critical PS, and pulmonary atresia. If you have wet lungs or pulmonary plethora, the diagnosis could be TG, transposition of the great vessels with intact ventricular septum, truncus arteriosus, tricuspid atresia, total anomalous pulmonary venous return, and single ventricle. So this presents, usually presents within the first 24 hours of life with severe cyanosis and respiratory distress. You will hear a single loud S2 and a systolic murmur of tricuspid regurgitation. Rarely you may have ST changes due to some subendocardial ischemia. And the difference in arterial PaO2 is greater than 10 to 20 millimeters, or oxygen saturation is greater than 5 to 10%. You may see poor lung recruitment and overdistension from PPV, which will worsen the hypoxic vasoconstriction due to increases in PVR and impaired CO2 clearance, resulting in acidosis. And treatment with vasopressors can further increase pulmonary vasoconstriction if you use high-dose dopamine. So do we have pulmonary hypertension in preterm infants? We talked about this in the normal transition being for the full-term infants or near-term or late preterm. Yes, in preterm infants, there is a decrease in pulmonary artery pressure after birth, which is significantly slower compared to term infants, especially if respiratory distress is present. And this elevation of pulmonary artery pressure may last for days. A lot of times, early pulmonary hypertension has been shown to be associated with development of bronchopulmonary dysplasia and late pulmonary hypertension, which in effect is a function of abnormal vascular development. Other risk factors for premature infants having pulmonary hypertension are oligohydramnios, which causes hypoplasia of the lung development, which could be either due to kidney disease or prolonged rupture of membranes, and delivery by C-section and extreme prematurity. So what are the etiologies of pulmonary hypertension? You have idiopathic, parenchymal, and hypoplastic. Here you see some of the etiologies. You can have retained lung fluid, meconium aspiration, asphyxia, maternal SSRI, and I'll go into details of these in a bit, but I love this diagram which explains everything. Pneumonia, respiratory distress, congenital diaphragmatic hernia, air leaks like pneumothorax, pneumomediastinum, and these are all the etiologies. So some of the mechanisms are parenchymal lung disease with acute pulmonary vasoconstriction like respiratory distress syndrome, pneumonia, sepsis, meconium aspiration. You can have maldevelopment because of poorly developed lungs due to some disorders like alveolar capillary dysplasia with or without malalignment of pulmonary veins, surfactant protein abnormalities like protein B deficiency or ABC transporter deficiency, chronic intrauterine hypoxia, antenatal duct closure, and 20% times you can have idiopathic pulmonary hypertension. The other disorders are pulmonary hypoplasia, which again can be due to diaphragmatic hernia or CPAM, that is congenital pulmonary airway disorders, or skeletal dysplasia. And then intravascular obstruction due to hyperviscosity or polycythemia, hypothermia. So these are the parenchymal lung disorders, which can cause alveolar hypoxia leading to acute pulmonary constriction. And most of you are familiar with meconium aspiration syndrome, GBS pneumonia, and specifically GBS is associated as part of sepsis. So any sepsis can cause parenchymal lung disease, but in the newborn, GBS is highly specific, and respiratory distress syndrome. You can have chronic intrauterine hypoxia or intrauterine closure of the PDA with remodeled vasculature and causing maladaptation. Or you could have BPD, which has reduced blood vessel density with remodeling and hypertrophy and hyperplasia of the tunica media. So the alveolar capillary dysplasia is a genetic defect. I'll just do a few seconds on this just because it's important. And any early antenatal insult prevents normal development of the pulmonary capillary bed. 40% have mutations for the FOXF1 transcription factor. You have surfactant protein B deficiency. And then, as we talked of, the ABC transporter 3 gene, which is mutations in the ATP binding cassette. These are just board questions. And you may be able to see some of these rare, you may have the luxury of being able to see one or two of these patients. And then congenital pulmonary lymphangiectasia, again, is abnormal dilated lymphatic vessels within the lungs. It's isolated congenital defect, and it may occur secondary to a cardiac anomaly or lymphatic obstruction. Associated syndromes are Fryns syndrome, Noonan's, Hunter's, and others. Pulmonary hyperplasia, as we talked about, due to congenital pulmonary adenomatoid malformation. You can see the x-rays here. Oligohydramnios or renal disease causing pulmonary hyperplasia with the bell-shaped underdeveloped thorax. and congenital diaphragmatic hernia, which all of you are very well aware of, and skeletal dysplasias just because of the thoracic problems. So this is congenital diaphragmatic hernia with the bowel, liver, spleen. Sometimes you can see the stomach going through the diaphragm. Intravascular obstruction due to hyperviscosity, due to polycythemia or twin transfusion, delayed transition due to birth depression or asphyxia or retained lung fluid in transient tachypnea of the newborn. And so the development of the disease involves complex interactions between antenatal factors and postnatal injury. So the antenatal factors being intrauterine growth restriction or maternal preeclampsia, oligohydramnios, or any sort of fetal inflammation, either due to rupture of membranes or infection in the mother, postnatal injury like ventilator-associated lung injury, any hyperoxia or hemodynamic stress. This will give rise to impaired angiogenesis and vascular pruning and increased pulmonary vascular tone. The oxygen index is one of the index that we use to assess how severe the hypoxemic respiratory failure is. And we calculate it by multiplying the mean airway pressure times the FiO2 divided by what is the PaO2 on the gas times 100. And if it is greater than 20, we consider INO. Less than 15 is mild PPHN, but 15 to 25 is considered moderate. Greater than 25 is severe. And if it's greater than 40, it's very severe, where we consider ECMO. The oxygen saturation index, I just wanted to talk about it, even though it's not used much, and we are evaluating it as a clinical tool. It is mean airway pressure times FiO2 divided by the preductal SATs times 100. So some of the antenatal risk factors can give you the clue if at all you are going to develop pulmonary hypertension. And as neonatologists, both Naveed will attest to this, we are very aware that if there is meconium in the amniotic fluid, we have to keep our guard up for development of pulmonary hypertension. Any acidosis, any asphyxia, and if we are giving therapeutic hypothermia to the baby for asphyxia. Other maternal risk factors are prolonged rupture of membranes, maternal fever, maternal infection, positive GBS status, post-maturity at 41 to 42 weeks or greater than 42 weeks. And then remember maternal NSAIDs or SSRI, which is the selective serotonin reuptake inhibitors, are also predisposing baby to elevated pulmonary pressures and elevated PaCO2. So as we talk, the hallmark features are hypoxia and labile saturations. The hypoxia and labile saturations are due to intrapulmonary shunts, secondary to ventilation perfusion mismatch, and extrapulmonary shunts, which we talked about, the PFO and PDA, which gives rise to labile hypoxemia. Here you can see this is normal. The center is, I don't know why
I'm just in a meeting.
the center is a normal VQ, ventilation to perfusion ratio, and then the right shows increasing ventilation to perfusion, which is vasoconstriction of the pulmonary vascular bed, where VQ is greater than 1, either in normal ventilated and under-perfused lungs, or over-ventilated and normally perfused. And on the left side is the VQ is less than 1 because of a diseased alveolus, where it is under-ventilated and normally perfused, or normally ventilated but over-perfused. And then you have the lability due to the extrapulmonary shunting at the PFO. When pulmonary and systemic arterial pressures are similar, then small alterations in the ratio of the two will produce large extra pulmonary shunting. And when pulmonary vascular resistance is close to or exceeds the systemic vascular resistance, then there is variable right to left shunting at the PDA and the PFO, and this will result in labile hypoxemic oxygen saturations. So what is the hallmark of PPHN? A lot of times we will tell the nurses, put the saturation, two saturation modes, one preductal, which is in the right upper extremity, and the postductal can be in the left upper extremity, or usually we ask for in the lower extremity. And if there is a duct present with elevated pulmonary pressures, there is a right to left flow. And if there is a 10 to 20 point difference between the pre versus postductal arterial PO2, then it is significant for probable pulmonary elevated pulmonary pressures, or if there is a 5 to 10% difference between pre and postductal saturations. This can also happen in left-sided obstructive lesions like coarctation of the aorta, interrupted aortic arch, and hypoplastic left heart syndrome, which you will pick up on the echo. All of these need an echocardiography. The other examples are obstructed TAPVR, transposition of the great vessels, tricuspid atresia, and Epstein's. The reverse cyanosis, differential cyanosis, happens when the postductal saturation is higher than the preductal, and that can happen in transposition of the great vessels with complete interruption of the aortic arch, or preductal coarctation, or DTGA with PPHN, or supracardiac total anomalous pulmonary venous return. So how do you differentiate if this is pulmonary hypertension or congenital heart disease other than the echo? Of course, if it is labile, so you will have a baby the nurse will say the SATs were 80 or 100, and she just touched the mode and nothing changed except the oxygen went down or the baby desatted. That is labile hypoxemia, and which is a hallmark of pulmonary hypertension. Of course, you may have history of meconium at birth or chorioamnionitis, and some patients may need to be transported on INO and prostaglandin. I don't know if we have enough time or I have to go quick. So the echo findings, we have an expert, Dr. Morey, who will also help with the point of care ultrasound. But the echo findings are usually the two shunts that you see, the right to left shunt across the pulmonary artery, the PDA, and the patent foraminal veil, deviation of the intraventricular septum to the left, of course, right ventricular hypertrophy, and tricuspid regurgitation, all of which are demonstrated in this diagram. I will go a little quick on this because this is the 5 views that we look at. This is the parasternal long axis. This is the parasternal short axis. And then you tilt it toward the hip to get the ductal view over there. And the axial 4-chamber view and the subcostal. So highlighting that normal, there is septal bowing to the right because the left-sided pressures are higher, but there could be a midline septum if there is bidirectional shunting, and then the bowing to the left, which is abnormal septal bowing, is created because it bows towards the left side, the right to left shunting. So here you can see it's a summary, and I'll go a little quick on this. This is normal circulation where the PDA is left to right and the PFO is left to right. So this is normal transition in a newborn baby. If the PDA stays bidirectional, or if the PFO is bidirectional, then you have mild to moderate PPHN because there is slight elevation of the pulmonary vascular resistance. However, if there is quite a significant right to left shunting at the PFO and the PDA, it is demonstrative of severe pulmonary hypertension. And of course, the IVS is bulging to the left, and then left ventricular dysfunction, you will have left to right shunt at the PFO. So again, if you have left to right shunt, that means the pulmonary artery pressure is lower than the systemic. It may be slightly high, but it is still lower than the systemic. Bidirectional shunting will be that the pressures are equal, and right to left is suprasystemic pulmonary artery pressures, which is not good. So the epidemiology of PPHN shows that there are pre-pregnancy conditions like maternal diabetes, asthma, or obesity. C-section has a 7-fold increase. Late preterm infants have a 2-fold increase. So I don't know how it is in Mauritius, but we have very specific indications for the obstetricians to deliver or induce a woman for labor prior to 39 weeks. 39 weeks is full term, 37 to 39 weeks is early term, and late preterm is 34 to 36. They have a 2-fold increase, and I have seen increases in early term infants too. And post-term infants greater than 41 weeks, if you have large for gestational infants and mothers with SSRI. SSRI use after the 20th week, there is a risk for, which is a moderate risk when you control for maternal depression. There is a concern that NSAIDs, which is aspirin, ibuprofen, and naproxen, used in utero can cause PDA closure, and large multi-center trial found no association between maternal use of non-aspirin, NSAIDs, or ibuprofen. However, we still worry about these mothers who have taken. The SSRI-exposed infants are more likely to have idiopathic PPHN without lung disease, which was in a large Swedish registry. And we all know that the Scandinavians have a great registry, and they have great studies coming out from there. So other instances are trisomy 21, which has a 10-fold increase, Black or Asian race, history of smoking, and then genetic variants, which we won't go into. So what are the antenatal strategies that we can reduce pulmonary vascular resistance? Avoid C-section. Avoid inductions prior to 39 weeks. Unless it is, of course, obstetrically indicated. I'm not a maternal fetal medicine person, but we work so closely with the maternal fetal medicine doctors and perinatologists. Delivery at or after 39 weeks is ideal. Antenatal steroids, please use antenatal steroids. Antenatal sildenafil is questionable, avoiding 100% oxygen during neonatal resuscitation. So we all start with 30% if needed. We start with room air for full-term infants, but 30% for the tiny babies, and establish a good functional residual volume. I think I'm going to go a little quick over this because this is just talking about the development of the lungs from the canalicular to the saccular to the alveolar stage, which affects pulmonary vascular resistance. Know that after birth, after the lung liquid is absorbed and an air liquid interface is established, with juxtaposition of capillaries, that will help decrease the PVR, pulmonary vascular resistance, and promote effective gas exchange. And rapid structural, within 12 to 24 hours, there is structural remodeling of the entire pulmonary bed from the main pulmonary artery to the capillaries to reduce the pulmonary vascular resistance. And here you can see the difference in the fetal pulmonary artery and the neonatal pulmonary artery after birth, which is nice and big. Also, there are the fully muscularized, thick-walled periacinar arteries are here. This is on the left, you see a normal pulmonary artery in a term newborn. It's only muscularized over here, but partially muscularized afterwards. In the intraacinar, there is no muscular area, but in pulmonary hypertension, you have increased vascular smooth muscle resulting from peripheral extension. And this can occur, it goes really down to the bronchioles and to the arterioles, sorry, and it can occur prenatally or postnatally. And here you see the changes in pulmonary resistance. There's not much difference in the fetus. If you look at the PO2 between the pulmonary artery and the vein, it's the same. However, in the newborn, because the ventilated alveolus with a nice PO2, you see there's a difference in the pulmonary artery and venous oxygen, but pulmonary veins are very sensitive to vasodilators, and that will help reduce both of them, pulmonary artery and venous dilatation, reduces the postnatal pulmonary vascular resistance. Excuse me. So what happens again at birth, recapitulating, is there is clearance of the lung. First of all, entry of air into the alveoli, clearance of lung fluid, increased alveolar oxygenation, and dilated blood vessels with reduced pulmonary vascular resistance. And this is accompanied by production of nitric oxide and prostacyclin, which is synthesized by endothelial cells. Within 5 minutes of birth, oxygen-induced vasodilation has occurred, and lung expansion decreases pulmonary vascular resistance to half of the systemic vascular resistance. And again, this just talks about the mediators that are stimulating the pulmonary vascular resistance. This is again a balance between the increased pulmonary vascular resistance or decreased pulmonary vascular resistance, and it is due to these mediators. If there's excess thromboxane or prostaglandin or serotonin or endothelin-1, these are all vasoconstrictors, and as you know, nitric oxide is the big vasodilator. So how do you manage? I have 10 minutes. How do you manage these babies? Of course, you evaluate the blood gases, glucose, lactate, coagulation studies. Is the patient a candidate for cooling? Because a lot of babies are asphyxiated. Assure appropriate lung inflation. That is the very, very, very important, is optimal lung inflation and not too much lung inflation and not under lung inflation. High frequency ventilator, particularly the oscillator, is very helpful, and inhaled nitric oxide. Of course, contraindication to inhaled nitric oxide is if there is any left ventricular dysfunction, and then treat RDS, meconium aspiration, and pneumonia with surfactant. This just talks about the back effects of this high pulmonary vasoconstriction causing increased pulmonary vascular resistance with decreased flow, decreased left ventricular preload, decreased LV output, and decreased systemic arterial pressure, which causes decreased coronary perfusion and myocardial ischemia, and decreased right ventricular contractility, which goes back to decreased pulmonary blood flow. So ultimately, there is high right ventricular afterload, and you could have LV dysfunction in severe cases. So what does nitric oxide do? It has a microselective effect and reduces intrapulmonary right to left shunting by preferentially dilating the blood vessels. It's a selective pulmonary vasodilator. It works best with adequate lung recruitment and preferably with high frequency oscillator. Doses greater than 20 parts per million do not increase the efficacy. So we start with 20 parts per million. And of course, one of the things we have to monitor is methemoglobin. Anticipate shock in pulmonary hypertension and increase lactate, and so treat hypovolemia aggressively with volume replacement, either normal saline or O-negative blood. And then because of coagulopathy, you may need a lot of blood products like fresh frozen plasma or cryoprecipitate. And then start hydrocortisone early and support blood pressure, because if you have a good systemic blood pressure, then it will be equal to the pulmonary pressure, or at least we don't want it to be pulmonary pressures to be suprasystemic. With significant left to right ventricular dysfunction, the right to left shunting at the PDA and PFO can serve as a pop-off and offset the right ventricular afterload and improve left ventricular preload. We need to support systemic blood flow, as we talked about, And sometimes we may need prostaglandins to maintain ductal patency to improve outcomes in severe pulmonary hypertension with right ventricular dysfunction and high afterload. So treatment of shock, first we need to know what is normal blood pressure. And we have a lot of nomograms for blood pressure. This I find is an easy one. Oftentimes I find the nurse will tell me that the blood pressure, at this blood pressure, the baby oxygenates the best. It is very fascinating to have an experienced NICU nurse who will tell you at the lability of the oxygenation or the oxygen saturations. So essentially by 6 to 18 hours, I always teach my residents it's about 80, systolic in the 80s, and then diastolics in the 40s with the means in the high 50s to 60s. Optimal therapy for reduced blood pressure, pulmonary blood flow is selective pulmonary vasodilation, which is inhaled nitric oxide. You can use dopamine, which is non-specific, norepinephrine and vasopressin are effective. But sometimes dobutamine can cause peripheral vasodilatation, especially if you're using milrinone. You shouldn't increase blood pressure to supraphysiologic levels because, again, it limits the right to left shunt across the PDA and may hasten right ventricular failure. Another word of caution is milrinone can cause hypotension and IVH, anticipate coagulopathy, and give sodium bicarb or acetate only if the CO2 is in the appropriate range. So we may have metabolic acidosis, but we cannot start treatment with sodium bicarb or acetate unless we have brought the CO2 down. Otherwise, it'll add to the CO2 load. Avoid excessive noise and stress, which can cause the PO2 plummet in minutes, and treat with narcotics. And avoid paralysis because it is associated with increased mortality. So treatment is positive airway pressure, improve the lung volume, give surfactant, improve metabolic acidosis, use inhaled nitric oxide from 5 to 20 parts per million, start hydrocortisone early, and then, of course, you have your pressors. You use sildenafil if you have normal cardiac function, and milrinone if there is cardiac dysfunction. And we can talk about sildenafil another day. It's almost time. So nitric oxide is a free radical. It can combine with superoxide anions to form toxic vasoconstrictor peroxynitrate. And so if you don't see any improvement with nitric oxide at 20 parts per million, you need to stop it. Also, hyperoxic ventilation with 100% oxygen, if you continue, it can increase the risk of formation of superoxide anions and limit the bioavailability of nitric oxide. And the best responders to inhaled nitric oxide are those with increased pulmonary vascular resistance and right to left flow through the PDA. As we said, if you have renal failure, low blood pressure, or myocardial impairment, they may not respond to nitric oxide. Discontinuing abruptly can cause rebound pulmonary hypertension and hypoxemia. And so we go from 20 to 15 to 10, and then 5, and then we go a little slow after that. Okay, we talked about this. And then this is an important one. Hydrocortisone decreases the phosphodiesterase 5 activity, and so cyclic GMP increases, and this will promote vasodilatation. So start early, start hydrocortisone early. Milrinone use an adjunct with INO, and it improves the contraction and relaxation. So anticipate a drop in blood pressure. Sildenafil, we talked about it, that it's a phosphodiesterase 5 inhibitor, but hypotension is a concern and we need larger trials. Smaller trials have shown benefit. Prostaglandin used to keep the ductus open serves as a pop-off valve, and then you have alprostadil that can be given. Prostacyclin, again, is a cyclic AMP-dependent short-acting vasodilator of the pulmonary and systemic circulation and reverses the vascular remodeling. Flolan or epoprostenol stimulates membrane-bound adenyl cyclate and increases the cyclic AMP. And then we have inhaled prostanoids, which this experience is largely confined to case reports and not many people use it. Bosentan is an endothelial. So we, in the other diagram, I may have gone a little fast, but endothelium 1 is a potent vasoconstrictor and vascular smooth muscle. And so bosentan is a non-selective inhibitor of both endothelial A and endothelial B, and it's a first oral drug approved for treatment of pulmonary hypertension in adults. It may have a role in chronic hypertension associated with VPD. So since this is my last thing, so yeah, I have a couple of minutes, Naveed. Can I do a case?
Yes, I think go ahead. I know we started a little bit late, so you can go a little more. And
Okay.
if people have to leave, they have to leave. That's fine. This is all recorded, so they can listen to it later on. So please go
Okay,
ahead.
sorry about that, guys. I really tried my best to have it on time.
No, go ahead. Finish your talk the way you planned it.
Okay, so this is just an example of a case, mother who you may have seen all of these. This is a common one. Mother who underwent emergency C-section after having a deceleration for 6 minutes, 38-week infant, born depressed, required positive pressure ventilation greater than 10 minutes, and then was intubated. Chest X-ray shows bilateral pneumothorax, and therapeutic hypothermia was initiated. Ventilation and oxygen issues on high frequency. So we put him on the oscillator, but we're still having high PCO2 and low O2. And then we did an echo. It shows right to left shunt with pulmonary hypertension. Of course, here you can see the two pneumothorax. So we put lines, we put chest tubes in. And this was a case of meconium aspiration, encephalopathy, and potential for seizures. We started therapeutic hypothermia. There was some adrenal insufficiency, shock, coagulopathy, and possible need for ECMO. Here we have the elevated liver functions, probably because of the hypoxia, asphyxia, coagulopathy, and elevated glucose because of the stress. So this is just an example of the cases that we see where there is meconium aspiration, and I don't know the percentage of meconium aspiration that will get pulmonary hypertension, but this is a classic example of a full-term baby or an early term. It was 38 weeks. Who will end up having pulmonary hypertension. I will open up to questions now, if you have any questions, guys.
Thank you, Dr. Chabra. That was an excellent overview of the topic. It was a lot of information, and I'm sure, people have watched it carefully. They will understand, and if they want to review it, it's going to be put on the WhatsApp as a YouTube video. So it is coming in a few hours, hopefully. But this is a good time for questions. I know it's late, but I think we'll keep it open, and people want to discuss or chat about anything. Feel free to either ask by unmuting your mic or putting it as a chat. I'm going to encourage the people who already are taking care of PPHN babies, especially the doctors, if they have anything that you want to ask as to initiate the discussion.
Hello, Dr. Hussain. What's up here? Hello, Dr. Chabra. Thank you for the presentation.
Hi, good evening, Naveed. Good evening, Dr. Shilpi. This is Dr. Kiran. Sorry, I was on another session, so I just joined. I thought I'll join the discussions. My video will start shortly. I think there is some issue.
Thank you, Dr. Moray, and for joining in. I know you were quoted earlier in the session. by Dr. Chabra. And I think she skipped over the point of care ultrasound very quickly. So I'm sure you will cover that when you do your presentation.
Yeah, yes, surely. I think there was one question about Maxwell somewhere I saw. Now it disappeared. I don't know. I think the Maxwell, I mean, Dr. Shilpi, you want to comment on that? Somebody wrote about Maxwell, any role.
Oh, I mean,
No,
magnesium sulfate is a vasodilator, and it reduces the pulmonary artery pressure and improves oxygenation. So we often will use it. We get the level done in babies, and it's a calcium channel blocker, so it will promote the smooth muscle relaxation. So very helpful.
But again, I
Dr.
think
Or?
it's not been used as a first line or second line, isn't it? Like in desperate measures only we are using it. Or are you using it routinely in your unit, Maxwell?
No, we don't use it. That's why it wasn't in any of my presentations. However, we always get an ionized calcium for all of these babies, and the calcium is low, we will give calcium, but also check magnesium, and then magnesium will help with the vasodilatory effect. But it's not the first line of treatment. I didn't see it in any of my slides, but it's a good question. And I don't know if the person was asking to give to mothers. Sorry, were you asking for mothers?
Neuroprotection? No.
I think that was Dr. Gill. If she's on, you can unmute and ask the question.
Thank you, Dr. Chabra, for your brilliant presentation. I would like to ask you one question. As you have mentioned in your presentation, inhaled nitric oxide should be avoided if there is left ventricular dysfunction. So what is the definition of left ventricular dysfunction in neonates? And whether you are getting a report after echocardiography, it's only done by eyeballing, means it's either good or impaired, or there is a certain ejection fraction which will make you to think twice about initiation of nitric oxide.
Yeah, I don't think there's any ejection fraction. Kiran, would you take that? If the cardiologist is not happy with the left ventricular contractility, we will not use.
Yeah. So I think, I mean, yeah. So rightly, as you said, like many times it's eyeballing, it's obvious, but you have to do quantitative, like so ejection fraction, fraction shortening. Suppose your FS is less than 25%, or if EF is less than 45%. There are again, as Dr. Shilpi said, no clear-cut definitions. Then we look at the LVO also, output. The LVO might be low as well. And so sometimes there is a mitral regurg, because of the dysfunction, there is mitral regurg. There could be abnormal IVRT, isovolumic relaxation time. There could be abnormal EA ratios. So we do a comprehensive assessment that tells us systolic versus diastolic dysfunction. And a baby who has significant like abnormal parameters, then we make an impression that, okay, this is definitely some kind of dysfunction. Also in the background, you will have maybe an asphyxia. There is an HIE, prolonged asphyxia, high lactate. So you know that, okay, this heart is really not functioning optimally. So in all those situations, you optimize the cardiac function first, and then you consider nitric oxide. Otherwise, you will cause a lot of this venous hypertension and back pressure changes, and you can make things worse. So presence of mitral leakage is also a subtle sign. It tells you that the left LV is not really functioning or contracting very well. So a lot of time we see this MR very severe. So in presence of MR and poor function, it's better to improve forward flow. So you have to use something like a milridone, which will improve the contractility and decrease the afterload. That could be a good drug to start before you consider nitric oxide. That's my take, but others can comment.
That was a good discussion on the point of care ultrasound and echo. Just to, the magnesium sulfate question was about babies with PPHN. That was clarified by Dr. Gill. So I think we have addressed that. And then There are a number of other questions chatted in. I'm going to quickly go through them and maybe we can have a short answer for that. So what about the role of fluids in babies with PPHN? Should we be cautious with fluids?
Well, I don't know about cautious with fluids, but fluid overload is always bad in any baby. However, we really need to maintain the blood pressure of this infant, and systemic blood pressure is extremely important to maintain, especially because you have elevated pulmonary pressures. And so that's why in one of my slides, I said we may need to give plenty of fluids for these babies to maintain the systemic pressure, and also give vasopressors like vasopressin and other blood pressure medications that we talked about. Cautious with fluid, I would say, when you say cautious with not overloading the baby. So sometimes we will use a fluid bolus of 10 per kilo and then see where we are at. But oftentimes these babies don't need 180 ml per kilo of maintenance fluids, but you can give fluid boluses and use for, coagulopathy, FFP bolus, etc.
Sharon has raised her hand. Do you want to ask a question, Sharon?
No, just wanted to add into that as far as the fluids go. Yeah, you do have to be careful, because if the underlying pathology includes HIE, you have to be very judicious in the amount of fluids you give to the babies, because of course, again, fluid overload is not good, and especially in those babies with HIE can cause cerebral edema.
Right. I mean, they will have SIADH. So we often start on the, thank you, Sharon. That's a good point. For the HIE kids, we will start just 40 ml per kilo, even though maintenance for everybody else we say is 60 ml per kilo. I will start 40 ml. Sometimes I even give 30 ml per kilo, just because they have SIADH and their sodiums are going to come back as 125 or 124, and then you're at risk for cerebral edema.
So the association of HIE and PPHN. So the question that was texted in is about therapeutic hypothermia. Would it worsen the patient with HIE and PPHN?
Yeah, so hypothermia is in an effect on its own a cause of elevated pulmonary vascular resistance. And so now you have two things that are causing the pulmonary pressure, elevated pulmonary pressures. One is the hypothermia, which is the therapeutic for the asphyxia. So asphyxia itself is a cause of elevated pulmonary pressures. Hypothermia is itself. And so both of them together can worsen the pulmonary hypertension. However, it is a therapeutic course, so we just have to do what we have to do.
Okay, there was a
Just have to
question
be
about
very careful.
methemoglobin measurement, and would they be different in terms of gestational age of the baby, or is the same for everybody?
No, I don't think so. I think it's just the same. We don't, yeah.
It is the same.
Yeah.
There was another question about congenital diaphragmatic hernia. Would you please advise whether you would use inhaled nitric oxide in case of congenital diaphragmatic hernia if ECMO is not available?
Yeah, I think so. I don't think it is contraindicated. We always will try to prevent ECMO, and I've often seen that INO is a nice, I mean, having done this for years before nitric oxide was ever there, Naveed, we both will probably agree that when nitric oxide came to this world of therapy for neonates, we said, whoa, life is so much easier. We just use this, add it to the ventilator, and then we're done. We don't have to cannulate the babies with VV, VA, ECMO, and all of that.
Yeah, so just imagine Mauritius has just started introducing nitric oxide. So their lives will change also.
Yes, we did it, what, in the 90s, mid-90s, early 90s, something like that at least.
Yeah. So I think, people in Mauritius will find out how useful nitric oxide is if they use it well.
Yeah, just
So
to add on, if I can comment, I mean, yes, I think we should definitely try. Only thing is that the non-responder rates in diaphragmatic hernias are higher. So many
Yeah.
babies, almost 40%, 45% babies may not respond. So then if there is a no good response, then there is no point in continuing it for very long. But you should definitely give it a trial because there is definitely some lung which will respond and the PVR will drop. So it definitely helps.
Yeah, but yeah, using nitric oxide for prolonged periods, we talked, can have side effects,
Correct.
or actually paradoxical effects.
So one of the questions chatted in, I think, kind of refers back to the magnesium sulfate question. I guess because of limited availability of nitric oxide, sildenafil, I think there was a question texted in. It says, "Hi, our access to medication is limited, even cardiac echoes. So just be aware, we use magnesium sulfate in Mauritius as sometimes to get sildenafil is also a challenge. Getting even milrinone, and nitric oxide is just recently introduced. So any comments about use of magnesium sulfate under those circumstances?"
Yeah, I'll have to read a little bit more on primary use of magnesium. You're really opening up a beautiful case of looking at evidence for that, and I always look for evidence when I get a difficult question. So I don't know the answer. For me, if the calcium is a problem, ionized calcium, we replace calcium, and often then we have to check magnesium and then replace magnesium. But just using magnesium for PPHN, I have not. Yeah, Sharon and Kiran, any ideas on
No.
that?
No, magnesium sulfate is not even a consideration. And I've not actually heard of it being used for this problem.
So,
I do
yeah.
know that, in the pediatric population, mag sulfate is used quite a lot for asthmatics because it's a smooth muscle relaxer. So
Yes.
I guess if you think about it that way, it could provide some benefit maybe. Or it's something that would need to be
Let's do a
studied.
clinical trial.
Yes,
Correct. So
let's.
yeah. I think as Sharon said, I think there theoretically there is a role. Again, we were in same situation in India around 2005 to 10. No nitric sildenafil had come in, but there was controversial use. So that time we used to use Maxelf as a desperate measure because there was nothing else to offer. But I think in PPHN, when you do good sedation and a good recruitment of the lungs, many times the PVR is going to drop. So whether the magnesium has worked or is it just natural drop in the PVR is difficult to prove. And I don't think there has been any publication in last 20 years on Maxwell because we were reviewing the guidelines. I think some papers are in 90s, maybe early 2000, but nothing in last 20, 25 years. So really no supportive evidence for that. But as a desperate measure, there is no
Did you
harm.
use it, you said, Kiran? You used it?
Yeah, we used it in India. We
Oh, for
use
PPHN.
Yeah. In the conference, we still get asked this question many times because there are
Oh,
in peripheries of India. Again, same thing. Sildenafil along with Maxel they use. Nitric is not there in majority of the cases. Sometimes getting IV sildenafil is a problem, and people have kept the baby NPO, so they go for IV Maxel rather than oral sildenafil. So very sick babies they have tried. So they do use. So I think some parts of India it is still practice, but most of the big centers are not using.
okay. The person who asked this question, I will respond to you. I will look into PubMed and see if there are some articles or case reports. Kiran, you should write it up.
Or you can just put it on the WhatsApp, our common WhatsApp group. I think that's
Yeah,
our
I will look for
best
it.
way. So everybody will get a chance to look at it. So a couple of other questions. If people don't mind sticking around, we can go through the questions. Is that okay?
Yeah.
I guess it's okay. So I'm going to go.
Yeah.
Another question was about BPD and babies who had PPHN. Does it make a difference in terms of the incidence, or can PPHN cause BPD?
So a lot of BPD babies will have pulmonary hypertension. That's not persistent pulmonary hypertension. That is just pulmonary hypertension. in the later stages, just because of the vascular remodeling and changes in the, as we talked about, the development of ventilator-associated induced lung injury and the congenital airway malformation, or the development of the vasculature with the bronchial development and cystic changes. So you will have pulmonary hypertension with BPD. Babies who have idiopathic pulmonary hypertension do have a higher, studies have shown that they do have higher incidence of BPD in the future. So that way there is a connection, but I don't think persistent pulmonary hypertension per se, once they have resolved, those babies will be fine. Percentage of the idiopathic pulmonary hypertension could develop BPD in the future. And then the BPD babies, or the preemies, will have pulmonary hypertension, but not persistent pulmonary hypertension or that transient fetal circulation.
A related question was
sense?
about the long-term effects of pulmonary hypertension after the lungs have healed. Are there any long-term effects?
Well, so when you talk of long-term, there have been studies, for neurodevelopment and development of asthma and some of the other respiratory issues. So these babies, especially if they have been very sick with the pulmonary hypertension and on ventilator or ECMO or INO, they will have effects on their neurodevelopmental outcome.
Yeah, and I remember when we used to use alkalinization for treatment, those babies had hearing deficits.
Yes, yes.
Yeah. Another question, I'm going through a little quickly now because it's getting late. So if the blood pressure is suboptimal in the case of PPHN, would you avoid starting nitric oxide prior to stabilizing the blood pressure, or would you do nitric oxide and pressure support simultaneously?
Yeah, I think that's 6 of one, half a dozen of another kind of a question. It's a great question, but we are sort of so desperate when we have a baby with pulmonary hypertension in front of us that we are trying to do everything, right? So we have to support the blood pressure. We have to start the pressors. You have to give fluids, correct the coagulopathy, give some fluid boluses, start pressors. And we talked about different kinds of pressors, and also start the nitric oxide. I would prefer to start the nitric oxide after the blood pressure is a little stable. And oftentimes the respiratory therapist will take, half an hour to bring the nitric oxide machine to the baby's bedside, and then another half an hour to put it through. So in that much time, probably we've already started the supporting the blood pressure. So all of this will take time to do, but I think that both have to happen at the same time, but preferably if I can stabilize the blood pressure before starting nitric oxide.
Yeah, and the good thing with nitric is it's deactivated immediately.
Yeah, very short.
The lungs, so it does not get into the systemic circulation. So that's good.
And just adding there, many times it actually helps also because one of the causes for hypertension in PPHN is the decreased preload on the left side of the heart. So because of the severe pulmonary pressures, the less blood is going to the lungs, less coming to the left side of the heart. So if you dilate the lungs with nitric oxide, the preload to the left side of the heart will improve and the blood pressure will improve. So I think it might be useful.
Yeah. So one question about diagnosis of PPHN is that 10 to 20 difference between pre and post ductal PaO2 is kind of what you mentioned. But is it common practice to do pre and post ductal blood gas, or are there other ways to kind of evaluate?
It's the saturations, usually we do the pre and post ductal
Saturations, not the PaO2 itself.
Not the PaO2, yeah.
Yeah. Okay, and what about when the PPHN is resolved and the baby is already on milrinone and sildenafil? Can they be just stopped, or do they have to be weaned?
That's yeah, I don't think that we often will do a wean on them. We usually just stop them. We wean the INO, inhaled nitric oxide, but the pressors, once we are confident, we will go slow. We'll peel them off slowly, not all of them. Oftentimes the babies are on multiple pressors. So we will peel them off one by one, but we just stop them.
Okay. Last question texted in. What about role of furosemide or Lasix in PPHN?
I mean, if you have fluid overloaded the baby, or if you have, you know, a lot of times it's going to cause negative effects if you give furosemide, especially if you are in so much trouble. What we are trying to do is increase our systemic pressure, because pulmonary pressures are so high, are suprasystemic. So we do not use Lasix. In fact, I think when I was doing my fellowship, if I used Lasix on any baby, actually, even not pulmonary hypertension, any baby, even a premature baby, we would get into trouble just because it is such a strong and it affects your metabolic situation so much that, you know, the metabolic changes in the premature baby will not correct for 7 days. So yeah, I don't use furosemide in PPHN babies. Of course, if you have overloaded or something has happened, then that's a different, for a cardiac indication, that's a different story.
Yeah.
Right. And the Lasix can also worsen if you have like elevated creatinine. It can make all that worse. So you're going to run the risk of having more renal failure.
Yeah.
Yeah. So that's wonderful question answer session. So I think if there are other questions, people can just text in the WhatsApp group that we have, the registered, which, you know, there are more than 170 people now on that. So everybody can benefit from the question and answers. So with that, I think we'll stop here. I'd urge you to go to the WhatsApp group and do the post test to get credit for this talk. The post test has 4 questions, and then there's also comments you can leave about how we can do this better, etc., and some feedback for us. So thank you again, Dr. Chabra, for an excellent overview.
And sorry, formal apology for messing up the Zoom starting. I tried to do it 3 times yesterday. It's the notes, I think. Yeah. So
yeah, I think it's so idiosyncratic with different machines and all that. So it's, I think, a common thing. It's not something
I know,
uncommon.
but everybody's time is precious. And so all of you have taken time away from your work to come to listen to me, and we wasted 8 or 9 minutes. So formal apology.
It was well worth it. Thank you very much.
Thank you.
So we'll stop here. I'm going to put this recording for the people who could not listen, maybe by the end of the day today. All right. Thanks again. Bye-bye. Next lecture is on Thursday, 8 p.m. And that's going to be on NRP. So you can prevent hypoxia and prevent PPHN.
Yes. Great.
Okay, great.
Thanks, guys. This is a
Thank you.
pleasure.
Bye-bye.
Good night.